talk about the LHINs tonight, and then we're going to entertain some questions if you do have any questions after the fact. Because what's becoming very apparent in a number of presentations that Mike and I have made around southwestern Ontario, from Grey Bruce down to Melbourne and Middlesex and Common County, as I say, is a lot of people don't really know what a LHIN is. And it's maybe a terrible acronym, but that's the title we have, which is the Local Health Integrated Network. It's a not-for-profit Crown agency responsible for planning, integrating, and funding local health services in 14 different geographic areas of the province. And that's exactly what it means. We manage the health care process, if you will, that takes place at the local level across the province in 14 different areas. What's in and what's out of the LHIN? I think that's important to know. Certainly hospitals are in the LHIN. That includes St. Mary's Hospital, that includes One Health Sciences Center, etc. Divested psychiatric hospitals, community care access centers, there's one in southwestern Ontario, community support service agencies, mental health, community health centers, and long-term care homes. But it's also important to note what's not in the LHINs, and Mike will go through some of the numbers part of it as well in a minute. But physicians in the clinics are not included in the LHINs. We don't fund physicians or clinics, nor do we fund ambulance services, whether it be emergency or non-emergency, laboratories, provincial drug programs, and public health. That money got controlled from another area, but not from the local health integrated network. So across Ontario, this isn't such a great map, but it does give you an idea of southwestern Ontario, which is item number 2. And on this map, you get a better idea. It goes right from Tobermory down to Port Rowan, Port Bruce, Port Stanley area. Covers a large area, 22,000 square kilometers, largely 1 million people, with a significant rural population. The elephant in the room is always London. That's the big multiplier when it comes to southwestern Ontario. But there are a large proportion of seniors, a small but growing proportion of immigrants in southwestern Ontario. We do have 5 First Nation reserves anywhere from this area, obviously, right up to the Bruce Peninsula. And French language services designation, which we've signed an agreement with the Erie St. Clair LHIN, which is the extreme southwest part of Ontario, with l'Alliance Française l'Europe, to give French language service to that part of the province. Health service providers in the southwest LHIN, as I say, there's 19 public hospitals on 32 sites, 1 private hospital, which is located in Woodstock. The 1 community care access center, so you can imagine the scope of that access center throughout southwestern Ontario. It's immense. 62 community support service agencies, mental health, addiction, community health centers. There's a lot of issues that we're trying to integrate the services in across southwestern Ontario, and then with the sister LHINs, whether to the southwest, or Wellington, or Simcoe, to the north, to the west, and to the northwest, to the northeast. We do have a 9-member board of directors. All of our board meetings are public, which is to say anyone can attend, and we do get relatively good attendance. I wouldn't say it's the best show in town, but people are welcome to attend our board meetings. And the packages are posted online in advance, and the videos are posted online after the events. I do chair the board, and have done so since the 1st of February. We have, you can read for yourself, the board members that are with us on the board. 3 of those board members will be leaving in the next 3 months, those being Janet McEwen, Murray Bryant, and Carrie Blagrave. We do think we have 3 replacements for those persons. We're waiting for information right now from the ministry in Toronto after these people have passed through standing committee, order, and council. So first prize is we have a full complement of board members, minus 1, which is the 1 vacancy. We do not have a person for yet, which we hope to have by the fall, and we'll have those people in place by the start of the summer, going into the September heavy duty period. LHINs, I'm really pleased to say this may not resonate very well, but it's a Made in Ontario approach, which is to say a lot of regional health councils, whatever it might be in other parts of Canada, have gone with a model that has created, if you will, a LHIN type structure, but where they've eliminated local boards. And it was very important to Ontario, it was very important to me when I was the board chair of One Health Sciences Center, that the local health service providers maintain their own boards. That means to say that there's governance at the local level, there's governance in the hospital, there's governance in the long-term facility, long-term care facility, whatever the case might be. So there's a voice that's being heard all the time in the local health integration network. Certainly created in response to the challenges and limitations faced by the regional health authorities, of which there are a number across Canada, working in collaboration with health service providers and their governing boards rather than supplanting them. I can tell you, when I was on the Board of Health, London Health Science Center, we did not let the LHINs push us around, and that's still the case. It's all about is integration, integrating services the best we can. There's certainly work to do yet, but I am pleased with what I've seen so far. As I say, I've been with the board since the 1st of February. Endeavoring to engage communities, listing knowledge and expertise and experience of health service providers in all sectors. And we do have open, transparent local decision-making. Our board meetings are open. We travel around the province. We take our board meetings, again, across the province. We were in Beaufort a few weeks ago. We were in Zurich before that, Ellen before that. And it's important that we do take the board away from London, if you will. So it gives people opportunities, whether it's in committees such as this, whether it's in other parts of the community, Grey Bruce, here on Perth, other parts of here on Perth, to let people see what's going on with their health service providers. And the 14 LHINs take on all responsibilities, funding and planning, which was previously handled by 23 offices across Ontario, which is to say 7 regional offices and 16 district health councils. That kind of gets lost in the translation a bit right now, I think, and I read the newspaper the same as you do. And I read in the paper this morning there was some issues being raised about the LHIN and its inefficiencies, etc. Mike's going to go through some of the numbers, and it's anything but inefficient. I say to a lot of communities such as St. Mary's, I live here too, and it's important to me that we try to do it right. So it's not as though I come here and then leave the planet or this part of the province. This is where we all live. And I can tell you, having dealt with district health councils and regional health councils when I was a hospital board member, the LHINs are doing a bang-up job. Could we do better? Of course. We'll never get it totally right, I don't think. But the bottom line is the integration of services where it can be made seamless, patient care, access to care being a huge issue is number one. Now I'll turn it over to Mike to talk about the numbers, which is always interesting.
Thanks, Jeff, and thank you, Mr. Mayor and Council. I always enjoy doing these municipal presentations because I spent the first 10 years of my career in the municipal sector, so I actually worked for the County of Oxford. My first job, I was the land use planner for the Township of Zora, so Uniondale and Chelmsford, places like that. And I was a town planner in Ingersoll, town planner in Tillsonburg, so very familiar with municipal work. And you'll see in Jeff and I's presentations that the link between what LHINs do and what municipalities do. And I think it's important. That's why we're doing and consulting with all of our municipal council partners around the Southwest LHIN. So these next 4 slides are pie charts showing the breakdown of funding from the government, from the Ministry of Health, and then from us. I'm sorry I've got my back to you guys here. You guys have copies of the presentation. So this is the overall funding for the Ontario government. So this is all the money that's spent by the province of Ontario. You can see that health consumes $46.1 billion, which is the blue piece of the pie on the right-hand side, which is about 40% of the budget. Education is $21.4 billion. Post-secondary training is $8.1 billion. You can see health consumes a significant portion of that budget. This next pie chart is the exact same thing, but it includes interest on debt. So it's the same breakdown, but it includes the debt, interest on debt payments that the province is making. You can see that that's $10 billion a year that the province is paying in interest on the debt that's accumulating. That's the fastest growing piece of the pie, and will be the fastest piece of the pie over the next few years. That interest on debt in the next 2 years will rise up to $12.3 billion on an annual basis, which means that the other pieces of the pie are going to have to shrink because as that increases, that piece increases, the other pieces have to be reduced down. Health is at 37% when you include that interest on debt payment. Now you take that last slide, the piece that's spent on health, $46.1 billion, and this is where all the money goes within the Ministry of Health and Long-Term Care. So this is all the health expenditures. You can see half of the Ministry of Health expenditures go to the LHINs. So the 14 LHIN organizations receive $21.5 billion, and we in turn transfer that to the hospitals, the CCACs, the community providers, mental health and addiction providers. So half of the Ministry of Health budget now goes through the LHIN system. The other big chunk of the Ministry of Health and Long-Term Care budget is OHIP. So this is physician payments. And you can see that $16 billion worth of the Ministry of Health allocation goes to OHIP, and the majority going to physician payments. So that's about 37%. If you look at public health, it's only 2%. So we spend all this money on taking care of people once they're sick and once they need care, but the upfront prevention and promotion is only 2% of the Ministry of Health budget is spent on public health. And then this final slide is the $2 billion that we have responsibility for. And you can see how it's broken down amongst the different sectors. So our 19 hospitals that we fund, including the Denver Healthcare Alliance here in town, is $1.48 billion, or 72% of our funding goes to our 19 hospitals. Other significant components go to long-term care homes. So the long-term care homes that we fund, there's 76 of them. The Community Care Access Center is $168 million, and you can see some of the smaller pieces in the community health centers and mental health and addictions. So why were these LHIN things created? So legislation was put in effect back in 2006 because you look across the system and each organization was great at taking care of its own business. So hospitals can take care of their own business. Community providers did a good job. Home care did a good job. But how did they work together? Under legislation now, the legislation that created us, now requires all these organizations to work together. So they have a legal requirement to consult and engage with other organizations across within the healthcare sector. Something that I always say is that you look at patient satisfaction surveys from hospitals, or you look at client satisfaction surveys from community agencies, everyone has really high satisfaction. So they're happy once they get into the hospital, the care that they receive, they're happy with the community provider. It's the two things that they're not happy with are wait times, waiting to get in. And the second piece is the transition between those sectors. So if you had to wait in the hospital for a long-term care home bed, or wait in the hospital to get to a community provider, or at home with a community provider, that's where the satisfaction drops. So that's where the LHIN can play a significant role in ensuring that those transition points are improved. We also have increased accountability. So for all that money that I described in the previous pie charts, we have an agreement that Jeff, as our board chair, signs with the Minister of Health for the $2 billion that they give us. They say we need you to deliver on a number of different performance indicators. And they include wait times, they include information around our finances, capital. We have responsibilities that we have to report back to the Minister of Health and Long-Term Care on. And then in turn, for all the money that we provide to our providers, the 150 providers that Jeff described, we have an accountability agreement with each of them. So we actually have over 200, 150 health service providers, but over 200 service accountability agreements. Because some of our providers may have more than one agreement. And a good example is St. Joe's in London. They have a hospital agreement, they have a long-term care home agreement, they have a community mental health agreement. So all these agreements, again, we give them the money, and they have to deliver on the indicators that we've asked them to around service and wait times. So for the first time in Ontario, we are measuring healthcare performance. We're setting targets through these accountability agreements, holding our organizations accountable. So if organizations aren't meeting those performance indicators, then we talk to them and say, well, why not? What's going on? And then we put a performance improvement plan in place to say we need to start picking it up in terms of whatever of those indicators that you may not be meeting. We're also publicly reporting these, and this is something that Jeff alluded to, is that in the past, decisions around healthcare funding, healthcare decisions, were all made typically behind closed doors. Especially the provincial decisions were made by bureaucrats in Toronto. All those decisions now are made in open public board meetings, at our board meetings that travel around. And we've had a board meeting here in St. Mary's last September, I think it was. Now we're at the Helen Golf Course, just down on the main drag here. So the decisions that are being made around your healthcare system are being made in open public settings, which never happened in the past. In our expenditures, and you'll hear in the paper that conservatives say the LHINs are taking money away from the frontline healthcare services. Our allocation is $5 million, so we run an office of $5 million with 32 staff and a number of other pieces that we fund through that $5 million. But our allocation is $2.04 billion. So 99.75% of all of our funding goes to frontline service. it's only that $5 million that we want as part of our organization that is being spent on the LHIN operation itself. So how do LHINs and municipalities work together? When I worked for the County of Oxford, I also was heavily involved in the 911 system, so I did a lot of work with the hospitals and fire and police. And I tell you, back then, the healthcare system was very separate from municipal work. They kind of went about their business, we went about our business. I think more and more, we need to have a lot closer relationship with our municipal partners, because in the recent things around the Here in Barrett Healthcare Alliance Vision 2013 process, it's very clear that those decisions in the healthcare business impact you as municipal council, and municipal council, your decisions that you make impact us. And typically, councilors are going to hear about it probably more so than us, because you're at the grocery store in town and at the library or the private or at the function, you're going to hear about it. So I think that's why we're doing this, so that we're open and transparent about what we're doing, willing to answer your questions, and if you do have concerns, we can certainly come back and have another dialogue about it. The last point here is that LHIN boundaries should not affect patient client or resident flow. This isn't a big issue in the same areas because you're kind of right in the heart of the Southwest LHIN, but on some of the periphery places, we've had instances where physicians have said, well, you're in the LHIN X, you can't come into our LHIN because we only service patients from our LHIN, which is contrary to the legislation. And we have the circumstance for us is typically arises when we have patients coming from Surrey, which is outside of our LHIN. Those patients, they cannot be restricted in terms of where they go. It's their choice and their physician choice about where they go, and LHIN boundaries cannot restrict that flow. So we have a number of examples of where LHINs have added value to the system, and the one that we speak to quite a bit because it shows how LHINs are performing from a system perspective, MRI wait times. So 3 years ago, our MRI wait times were 169 days. Those wait times are now 64 days. How did we do that? We have MRIs in the two London hospitals at St. Joe's and LHSC, and then we have an MRI in Owen Sound up in the Great Bruce. So those are all the MRIs that are in our geography. 3 years ago, the wait times were very high in London hospitals, over 200 days, but very low in Owen Sound because they just got their MRI. They didn't have the volume to actually, so their wait times were quite low. They're down about 28 days. So each of those hospitals went through a process to streamline how patients go through, so make the most effective use of the time so that it's operating as efficiently as possible, just like in business, you do something with a lean exercise. But the other thing we did is that with this geographic separation between the two sites where you have MRIs, we sent a letter to every family physician and said, if you need to refer your patient for an MRI, send them north. They don't always need to go south. There's this perception that people are going to get better care in London because it's the big hospital and they have all the subspecialties there. If someone's looking for an MRI, they can go, especially in the here in Perth area, they can go just as easily north as they can go south, and the MRI wait times can be significantly lower for that patient. And we've seen the results. Owen Sound's wait times are now higher because more people are going up there, but the wait times in London are a lot less, and they can have better patient flow through that MRI. You'll see there's a slide at the end of the deck that talks about our wait times for CT, knee replacement, hip replacement. All those have dropped significantly since the inception of LHINs. We also have the third example here is the LHIN policy. In the past, when hospitals operated as separate organizations, if you had a situation where a physician was calling from Listowel and said, listen, I got to get this patient into LHSC, his life is threatened or limb is threatened, that hospital, I shouldn't use LHSC as an example, any hospital could say, we don't have any beds available, so we're not going to take that patient, and then that physician has to call somebody else, and they end up calling Kitchener-Waterloo or calling someplace or getting them to a place that could actually receive them. Mike Sharp, who's our critical care lead, a physician at University Hospital Intensive Care Unit, he's now implemented a policy across the entire Southwest LHIN where if you have a patient that's threatened with life or limb, and you make a call to a hospital, that hospital has to receive them. And it seems like, it kind of makes sense if life or limb is threatened, but in the past it didn't work that way. And until you had this regional system of care where hospitals were working together as a system, now they have the requirement to actually do that. The last piece, and I'll try and wrap up here, Mr. Mayor, to allow time for questions. hospital records to get to a family physician office will be faxed. Who uses faxes anymore? The hospital, the healthcare system still does. So these records would go back and forth, lab results and diagnostic imaging results. They send them to the family physician office. The fax machine would be out of paper, it would be broken down, no toner, like things like that, but it would have an impact on the care for that patient when it's all said and done. So we've now implemented a project called SPIRE, which is the Southwest Physician's Office Interface Regional Electronic Medical Record System, where it allows the downloading of hospital records directly into the EMR, the electronic medical record of the family physician. So it's done electronically now. In a very short period of time, we have over 350 physicians connected now. We're leading the province in this, in terms of moving this forward, and we intend to have up to 500 physicians signed up by next year. We have a number of priority projects within the LHIN system. I'll speak briefly to them. Home First is where we need to make sure that people are, the ultimate destination for someone is at home. It's not in a hospital, it's not in a long-term care home. They need to get home first. And if someone's in a hospital getting care, we should do everything in our power to get them home with the proper supports in the community. I'll skip through to talk about, or I won't touch on a lot of this, I'll leave some time for questions because I want to make sure you have an opportunity to ask Jeff and I some questions here. Lots of challenges. Our wait times for cancer surgery are the highest in the province. So our LHIN is number 14 of 14 on cancer surgery wait times. Mental health divestment, we're moving mental health beds from the City of London to other parts of the province, which is creating significant change within the system. It's a good thing, but lots of change. And I think in the past we had this siloed approach to care, and I referenced we referenced the here for Healthcare Alliance Vision 2013 process of looking at things from a system perspective across 4 sites, as opposed to looking at each site individually. Here's some of the results from our wait time, which I referred to earlier, and I'll leave it at that, and we're happy to answer any questions.
Yes, the Conservative government seems to have done a pretty good job, a good number on you guys. In fact, as I left the house tonight, Hudak was on television at that time.
They're still in opposition. Yeah, they're not in government yet.
I know. And then one of the things that they really put out is the idea that it is another layer of bureaucracy. And in reality, it is not another layer of bureaucracy. But what I don't understand is why do you people or the Liberal government not fight back? Like tonight, I figure I follow the paper and the news quite closely. I was well aware it was not another layer of bureaucracy, but I certainly was not aware that a 99.5%, because they've done a very good job of saying, all you guys are making a ton of money, and there's none left for us, you know, sort of thing. And it just bothers me, because the longer that it goes like that, and they wait till the election comes, you're going to see that the people will say, oh no, it's just election time. And is there any reason why you haven't corrected this immediately? Or?
I'll start, and I know this, Jeff likes to speak to this one as well. I guess one, it's difficult to fight when we've got a communication budget of $50,000 or whatever ours is, and having the camera here tonight is not to promote Jeff and I, it's to promote the message that we're giving, because we post this on our website, it goes on the YouTube site for us, and I'm sure you heard before when we were talking about this that our videos are now the 11th most watched video for a non-profit organization in Canada last month. So we do try and get the message out. It's very hard. We work closely with our media contacts from across the Southwest LHIN. Typically the media wants to have a story that's a bit more controversial as opposed to something that's giving you the facts about it of LHIN. I think that one of our biggest successes recently is that the London Chamber of Commerce, they submitted a pre-budget consultation to the provincial government about a month and a half ago with a number of recommendations, and one of the recommendations was to hold the line on healthcare spending. The second recommendation was to close LHINs because they're an unnecessary layer of bureaucracy. The minister was very concerned about this, and so she called a meeting between herself, us, and the London Chamber of Commerce. And at the end of that presentation, doing something very similar to this, the LHIN chamber said, geez, you know, what was in place before? There was 70 or 80 staff working in those 2 offices that covered our area. There's now 32. Decisions are made locally. There's no big government centralized decision making. It's all made in the local arena. So we try and get the message out. We hear consistently about getting your message out more clearly. We do all kinds of things to do that. It's just very difficult to sometimes get that message across.
I won't say anything.
Well, I guess what bothers me is if the LHINs are functioning well, and according to you people, in comparison to a previous setup, they are doing very well. They're making strides in areas that need to be, like cancer treatment and stuff, although a lot more has to be done there. Then I think it would be a shame to eliminate something that is successful. And I think that people should know that.
I agree.
And I'm not saying I'm conservative or liberal. I mean, I don't even know what I am, but it just tends to bother me. It's not a level playing field.
You know, I've been involved in the volunteer aspect of healthcare for 16 years, and I wouldn't have bothered with the LHIN if I didn't think it was the right way that things are going right now. Again, regardless of government. Just look at like Facebook, Twitter, YouTube, LinkedIn. The social media is where a lot of our messaging is getting out. I read the article that was in the paper this morning by Mr. Wilson, talks about, Mike and all those fat cats making all this big dough, and that their numbers have quadrupled. Well, there was only about 8 of them there when Mr. Wilson was last around this neighborhood. There's 32 of them that are now carrying out a lot more work. So just by the process of numbers, yeah, it's doubled or tripled. If for no other reason, there's more people. The bottom line is that I work with district health councils, I work with regional health councils. They were great people, and they really busted their behind trying to get a lot of things done. But they couldn't produce, they couldn't come through. And the way the system is right now, it's the authority to make decisions with healthcare have been not delegated, they've been devolved to the LHIN. In other words, the hospital can't go behind our back, if you will, to the minister and say, hey, listen, don't listen to them, we need this. The minister has given up, literally given up that power to the LHIN to make those decisions. And because it's transparent, if it's not the right decision, it doesn't take long before we hear about it. I would love to mount a great PR campaign, and I feel Mike's icy stare on my back as I say that. And hopefully we will find the right time to get the message out so it doesn't appear to be just an election gimmick. Because I'm like you, I don't care whether it's the NDP or the Doukhobors that are in power. At the end of the day, I live here too, and it's all about healthcare, and we've got a good thing going here. I can't imagine why we blow it up and send it all back to Toronto and ask them to do it for us.
Councilor Bennigan, question?
Thank you, Your Worship. Absolutely. I mean, this, as you said, does come to us on a regular basis. We've had, I think, 4 delegations in the short time this council has been sworn in on an issue that we had no vote on. So I think it probably takes the cake in that respect. But as much as we can have a dialogue, maybe we can bring a little bit more accountability to the decisions that are made. So these times are good. I was looking at the comment in your examples of value slide, which talked about patients can't be refused treatment in an intensive care unit of hospitals. And this really sounds like a familiar issue when we bring it to the local level, which is what we've been hearing about so much. And that is, what is the future of the emergency room in St. Mary's Memorial Hospital? For 50 years, that hospital has operated an emergency room, and the community just can't fathom the idea that for some reason it can no longer be workable. And I'm wondering if, obviously this is worded not for ERs. I love that it was. But do you have any sort of policy with regards to emergency rooms that we should be looking towards when you are considering the future of the current Kirkland Healthcare Alliance plan?
So there's quite a few components to that. I think one is, yes, we have strategies around small departments and small hospitals. I spend a great deal of my time in the summer months with getting a call from the hospital CEO on a Thursday or Friday saying, oh, that shift on Saturday night's not going to be covered because they don't have a physician to be able to cover the shift. And this isn't just St. Mary's, it's Southampton, it's Kincardine, all across our LHIN Lions Head, all which have emergency departments. So it's a challenge to staff emergency departments in small communities, especially with the new focus on primary care from the provincial government, which makes it much more attractive to be a family physician and not work those shifts in the emergency department and working overnight or an additional shift, which always was the case with family physicians. So we looked at this issue. We have a report with a number of strategies that are identified on how we can do things differently in emergency departments. You know the recommendations that have come forward from the Vision 2013 process around reduced operating hour emergency departments across the 4 sites within here in North Carolinas. The government and the ministers made it very clear that no decision around that is going to be made until such time as the ER task force has completed its work and looked at things across the province. Because the minister and the government has made it very clear that they don't want something, a one-off happening in St. Mary's. They want a consistent policy across all emergency departments, in Ontario. That ER task force hasn't finished its work yet. I have a question will be when, and I don't know the answer to that. But as of right now, we know what the recommendations are, but the decisions are not going to be made until such time as that ER task force has done its work. But I guess to answer your question, we do have a strategy report which is on our website, which lists a number of strategies about how we can make more effective use of our emergency departments, especially around the HR component. Because as you know, in C4, it wasn't just physicians, it was a nursing issue that led to the reduced operating hours overnight there.
So specifically to St. Mary's, does that strategy still include hospital closures? For certain times a day?
So we haven't put forward a strategy for specific sites. These are strategies for small emergency departments across our LHIN. So it hasn't, our strategy doesn't say St. Mary's is going to be this or C4 is going to be this. It's strategies around how we deal with this very problematic issue of staffing emergency departments in small communities.